Hello everyone. So in this section of videos we will be studying about leukemias and lymphomas. So this is the first part in relation to that. First we need to understand the difference between leukemia and lymphoma. Leukemia is basically originating from the bone marrow and lymphoma is originating from the lymph nodes. That is what we need to remember. In the leukemia the cells will be found in the peripheral blood. Then next we have difference between Hodgkin and non-Hodgkin lymphoma. What is common between them is both may have constitutional B signs and symptoms, that is low grade fever, night sweats, and weight loss. Then Hodgkin's lymphoma is a localized single group of nodes with the contiguous spread and the better prognosis. While non-Hodgkin, multiple lymph nodes, extranodal involvement, non-contiguous spread, and worse prognosis. Then Hodgkin will have Reed-Steinberg cell RS cells, and non-Hodgkin will have B cells and rarely T cell lineage. Then Hodgkin's has bimodal distribution, that is young adults and more than 55 years. Non-Hodgkin can occur in children and adults. Okay, so the specific age distribution is there in the Hodgkin's. Then Hodgkin's is associated with EBV and non-Hodgkin's may be associated with autoimmune diseases and viral infections. Here not only we have EBV but also the HIV virus and the HTLV virus. And which nodes are commonly involved or which lymph node groups are commonly involved in non-Hodgkin? Waldeus and mesenteric rings. So, what is the difference? Hodgkin's is localized, single group, contiguous spread, better prognosis, and it is multiple extranodal non-contiguous worse prognosis. RS cells, here B cells and T cell lineage. T cell is rare. Then young adults and more than 55, here nothing specific. EBV, HIV, HTLV, and autoimmune diseases. Then now coming to the Hodgkin's lymphoma, it contains Reed-Steinberg cells, distinctive tumor giant cells, bilobed nucleus with two halves as mirror images. Okay, so the classical of the Hodgkin's lymphoma is Reed-Steinberg cells, and these have bilobed nucleus. Bilobed nucleus will be present, and these two lobes will be looking as mirror images of each other, and this is also known as owl-eye nuclei. Then next we have the subtypes of the Hodgkin's. Okay, nodular sclerosis, mixed cellularity, lymphocyte rich, depleted, and the another subtype is lymphocyte predominant. Okay, sclerosis, cellularity, rich, depleted, and predominance. So these four types, nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted, are a type of classical Hodgkin's lymphoma, and it is CD15 and CD30 positive. While lymphocyte predominant is CD20 positive and CD15 and CD30 negative. Then next we have the EBB positivity. EBB positivity is present in all the three types except nodular sclerosis and lymphocyte predominant. Okay, the one with sclerosis will not help enter the EBV into it, and with the lymphocyte predominant also. Then what are the cells in the specific subtype? The nodular sclerosis will have lacunar cells, mixed cellularity and lymphocyte rich will have RS cells, and lymphocyte depleted will have reticular variant, and lymphocyte predominant will have popcorn cells. Okay, predominant popcorn cell. Depleted, P for predominant, P for popcorn, depleted have reticular cells. Sclerosis. In the sclerosis, lacuna will be created. Okay, lacunar cells. And the other two type have RS cells. Then the nodes, specific point about that, nodular sclerosis is most common in the world and in the young adults and in the females. Okay, well, mixed cellularity is most common in the India. Imagine mixed population is there in India. So mixed cellularity is most common in India and eosinophilia is seen. Then rich, lymphocyte rich, best prognosis. Rich have better bank account. Then lymphocyte depleted, worst prognosis. The poor have worse bank account. And lymphocyte predominant also has best prognosis. So what we need to remember about each subtype is what is the CD markers that are positive, whether EBV is positive or negative, what are the cells present, and the prognosis. Okay, EBV in the 3 is positive. Not having is nodular sclerosis and lymphocyte predominant. Lacuna in sclerosis, reticular in depletion, and popcorn in predominance. Best prognosis is with the lymphocyte rich, and worst is with the lymphocyte depleted. Most common in India is mixed cellularity. So many MCQs are covered in only this much part. So this is very important to remember. Then next we have specific notes about it. Pathology, latent membrane protein. In the Hodgkin's lymphoma, latent membrane protein causes activation of NF-kappa B. Okay, latent membrane protein is involved. Then Reed-Steinberg cells. These are derived from the germinal center or post-germinal center. Bilobed nucleus with prominent eosinophilic inclusion-like nuclei. CD15 and CD30 positive. CD20 and 45 negative. These will be positive in the lymphocyte predominant one. Then histological diagnosis reads Steinberg cell along with the background of mixed inflammation, that is neutrophils, plasma cells, eosinophils, histiocytes. Necessary in the diagnosis. Okay, Reed Steinberg cells are necessary in the diagnostic and have high negative predictive value. Means if the Reed Steinberg cells are not positive, it is most unlikely due to the Hodgkin's lymphoma. And it is also seen. Reed Steinberg cells are also seen in infectious mononucleosis, immunoblastic NHL, carcinoma, and sarcoma. Okay, so Reed Steinberg cells are specific for Hodgkin's, but it can also be seen in other conditions like infectious mononucleosis, immunoblastic NHL, carcinoma, and sarcoma. Then clinical feature painless cervical lymphadenopathy, Pell-Epstein fever, that is intermittent fever every alternate week. Okay, intermittent fever occurring every alternate week is called Pell-Epstein fever, and paraneoplastic syndrome. Affected lymph node become painful with alcohol ingestion and secondary amyloidosis. Okay, the specific history can be given that affected lymph nodes or the pain happens more after alcohol, and secondary amyloidosis history can be given. This is classical of Hodgkin's lymphoma. Then adverse prognosis. Adverse prognosis age more than 45, male, serum albumin less than 4, stage 4, and hemoglobin less than 10.5, leukocyte count more than 15,000 per mm cube, lymphocytopenia, absolute count less than 600 per microliter, and less than 8% of the leukocytes. So, what are the adverse prognostic features? Age is more, male gender, then serum albumin less than 4, and stage 4. 2 fours are there. Then hemoglobin less than 10.5, leukocyte count. Leukocytes are more than the adverse prognosis. But lymphocytes which are responsible for immunity, that are less, that will be adverse prognosis. Less than 600 and less than 8%. So that is all what we need to remember about the Hodgkin's lymphoma. The next ones we will be covering non-Hodgkin lymphomas in the next video. I hope you will find it useful. Thank you.